Greetings of the day, everyone. For those who have been attending the Radiology International Lecture Series, I'm Dr. Vinita Sharan. I have been the advisor for CME for Radiology for GAPIO, and we have been doing these webinars since November 2022, and this is our 16th or 17th webinar so far. So, welcome to the Radiology International Lecture Series. The topic today is role of imaging in oral and tongue cancer. Unfortunately, one of our speaker, Dr. Sonal Mahalwar, she is not able to participate because of injury. And I'm very thankful to Dr. Suresh Mukherji for taking over the topic and covering for her. So thank you, Dr. Suresh. And in the interest of time, I would like to hand over to the moderator, Dr. Asutosh Sahu. Dr. Asutosh Sahu, he is a fellow in emergency, trauma, and acute radiology at the University of Toronto. He has pursued advanced training in neuroimaging at King's College London under the prestigious Commonwealth Scholarship. And next year, Dr. Sahu will be joining the Boston Children's Hospital, Harvard University, Harvard Medical School for a fellowship in pediatric radiology. Following this, he will be assuming the role of assistant professor in the Department of Radiology at University of Michigan Medical School, where he will be working both in pediatric as well as cardiothoracic imaging. Dr. Sahu's clinical expertise is further strengthened by his robust research portfolio with several peer-reviewed publications, numerous conference presentations, and ongoing research projects. And he has also been our speaker for a couple of times. And I am also going to welcome Dr. Jayesh Shah, who has joined now. So, Dr. Sahu, you may take over the moderatorship. Thank you.
Thank you, Dr. Sharan, for giving me the opportunity to join as a moderator in this season. And I'm quite fortunate to give a couple of lectures in the last year as well in this prestigious GAPIO platform. And it has been a wonderful experience for me. And sharing knowledge has always been my passion, and I'm happy to do that in future. So let's get started. And I'd like to introduce the chairperson for the session, Dr. Jayesh Sharma, who is a senior consultant surgical oncologist at LTM Medical College in the Greater Raipur Area. Dr. Jayesh Sharma is a renowned consultant of surgical oncology, and he's a consultant in India specializing in surgeries of the breast and head and neck cancer, and he has more than 20 years of expertise after his fellowship, and his passion is to give his patients not just the care or the cure, but a high quality of life. He was the founder of head of large cancer center in the new Raipur area and has led the surgical division. So I'd like to welcome Dr. Jayesh Sharma to our podium, and I hand over to him.
Yeah, thank you. Thanks for having me over for this meeting. Sorry for being a couple of minutes late. It's a privilege to be part of this esteemed meeting. I would like to introduce Dr. Saurabh Mukherji, MD, MBA, FSCR. He is a professor of radiology, University of Louisville and the University of Illinois, professor of radiation oncology, Robert Wood Johnson Medical School at Rutgers University. He is a faculty in otolaryngology and head and neck surgery, Michigan State University. He is a faculty in oromaxillofacial radiology at Texas A&M University, National Director of Head and Neck Radiology at ProScan Imaging, and a Bruce Bradley Fellow, the DeepTek. He's an honorary member of Indian Society of Head and Neck Radiology and Hungarian Society of Neuroradiology. Now, before I hand over the podium to him, I would like to present a little bit about a surgeon's experience, how a surgeon feels about head and neck oncology. And the thing that I would like to start with is what has been the change in head and neck oncology, especially from a perspective of a surgeon, the last 25 years that I've been practicing. So I started working in head and neck oncology around the year 2001. And it's been a sea change. It's been a complete overhaul of how we look at oncology, how we look at our patients, and how we look at the disease of oral cancer specific. Right from the stage of diagnosis, when doing a CT scan was considered optional in India around the year 2000 for head and neck oncology surgery, to the era of not just CT scans with contrast, MRIs for specific use cases, PET scans for the patients who need them, and narrowband imaging now to use for not just for diagnosis, but to pinpoint the accuracy of both resection as well as biopsy. And so this is just in imaging and in diagnostic methods. I like to look at it as something of a change which is very similar to how we changed in wars. Now, this is a sensitive time to talk about wars, but let's move beyond that and look at uh, there was a term called war on cancer, which was very widely used. And it involved basically us standing on one side, cancer on the other side, and we using all the force that we can muster to attack on that cancer and destroy as much of it as. The term collateral damage was not there in military oncology, in military terminology, nor in oncology terminology. And I use the example of when in 2001 Osama bin Laden was being hunted. A whole mountain range called Tora Bora was destroyed because they had an intel that Osama was hiding there. When he was actually found, and that mountain range was destroyed, and Osama was not even found at that place. When he was actually found, it was through a precision operation where they gathered intel, where they sent a specialized team, where they conducted a very pinpoint operation, and the building in which he was residing was also left standing at the end of that operation. That is how much oncology has also changed, especially surgical oncology in last 25 years. So we first gather information. As we talked about, we gather information about diagnosis and imaging using our tools. Then we send a specialized team. Nowadays, surgical oncologists overall are not all of them doing all kinds of cases. We work in teams of MDTs, which are multidisciplinary tumor boards, and we decide on a course of action based on that MDT decision, which involves not just the surgeon and radiation and medical oncologists, but also radiologists and nuclear physicians, as well as pathologists of all varieties. So those are the kind of MDTs. That's the specialized team that we say. Then we use advanced treatment methods. So laparoscopic and endoscopic surgery has been a part of surgical armamentarium since the 1980s. But use of robotics has increased the precision in head and neck oncology as well in doing resections in oropharynx and hypopharynx. It has improved our accuracy in head and neck, in thyroid definitely, but also increasingly we are doing more and more of neck dissections using robotic techniques, which has led to a scarless and better outcome for patients. So coming now to intrude less, which is the another thing that they did in Osama bin Laden's actual operation versus what happened in Tora. So we don't make as big incisions these days as we used to do. So when I started learning composite resection, we used to routinely split the lip, bring it down here, make a vertical Y-shaped incision in the neck, and lay open the entire field. Now, most of my cases are done via a single transverse skin crease incision in the neck, and we are able to resect mandible and sometimes even part of the maxilla just via that incision, even without using endoscopic surgery. Because we have learned the value of not doing a lip split, how it affects not just cosmetically as well as functionally. We have learned the principles of surgery better, we have better equipment, better lights, and we are more attuned to doing those kinds of surgeries. So intrude less. Now, the third point that we generally do is resect less. So when we started doing head and neck oncology surgery for a 2 centimeter tumor on buccal mucosa, not reaching up to the sulcus, not reaching close to the gums as well, we would do a composite resection, which is still the name that is being used. But composite resection means removing the primary part of the mandible plus all the neck nodes in one composite block. And we used to do a comprehensive neck dissection, sometimes even radical neck dissection, which which causes its own lots of morbidity and mortality. Now, I can tell you, even in a high volume center, in a country like India, where we see a lot of advanced cases, I have not done more than 2 or 3 actual radical neck dissections in last year or so. We do modifications of neck dissections because we understand the biology of spread better. We are more confident in predicting the biology of spread. We the thought behind removing the mandible in all cases is that lymphatics traverse through mandible. So even if the tumor is not reaching close to the mandible, you have to remove the entire segment of mandible just so that you get complete clearance. We have now realized that that is no longer. We hardly ever do segmental resections for T2, T3 tumors anymore. Unless the mandible is actually involved, we we can get away with doing a wide resection of the primary and some kind of selective neck dissection rather than doing a large mandible resection in any of those cases. Then we come to leaving the whole thing intact. So plastic and reconstructive surgery has made huge leaps in last 20-25 years. Pre-flap surgery in India was in its infancy when we started. We were amongst the first people in Western India to start doing free flaps, but now free flaps are our workhorses. That means we don't reconstruct using whatever is available nearby. We select what exactly kind of tissue we need, and we get it from any part of the body where we can harvest it from. We use microvascular reconstruction to ensure that the part that we are putting in receives its blood supply properly, and we also use uh, multiple complex flaps derived from either single or multiple vessels, so that, for example, if we have to reconstruct the tongue, the mandible, and the buccal mucosa, it will be a composite flap where one part will make a tongue flap, and another part will make the buccal mucosa and the mandible flap, so that tongue can still remain mobile. Earlier, what we used to do is put a large flap which extends from the buccal mucosa, crosses the mandible, and attaches to the tongue. The tongue becomes fixed in place in those kinds of cases, and it's practically only for the cosmetic value and for the psychological value that we have retained the tongue. Now we are using a lot of complex flaps to ensure that our reconstruction is good. And for all this, we need radiologists like Dr. Mukherji to help us figure out exact extent of the disease and how we can approach the disease safely without causing it to, without leaving it open to recurrence, as well as giving a good chance for cosmesis. Now, that's my surgical perspective. That's my semi-historical perspective. And now I hand over to Dr. Mukherji to take it further and enlighten us about head and neck radiology. Dr. Mukherji.
Great. Thank you very much for the wonderful surgical perspective. And hopefully, Vinita, can you see my screen?
Yeah.
Now?
Yes, we can. Yes, we can see.
And you can hear me okay, I assume, right?
Yeah. But your
Great.
screen is, yeah, now it's full screen. Yes.
Fabulous. Okay, great. So thank you for having me on this webinar, and thanks for everyone for attending. What I'm going to do is give a talk on squamous cell carcinoma of the oral cavity and the oral pharynx. And just purely because of time, when you come to our annual meetings, we have hours and hours of sessions on the oral pharynx and the oral cavity, also on lymphatic drainage as well too. So just purely for the sake of time, I'm going to focus my talk on the oral pharynx in the oral cavity. I'll mention maybe a little bit about the lymph nodes, but I won't spend that much time on it because that in itself is a separate talk, but I'll try to allude to it as possible. So we're going to first start out about the oral pharynx. And I think from my standpoint, when I talk about radiology, it really is all about anatomy. So regardless of where you're from, whether you're a radiologist or an ENT surgeon or radiation oncologist or general practitioner, the one common language that we have is anatomy. So when we look at the subsites of the oral pharynx, it's divided into the tongue base, the soft palate, the tonsil, and the posterior pharyngeal wall. And when we look at the anatomy of the oral pharynx, the anterior portion is through the circumvallate papilla and the anterior tonsillar pillar. Then we have the posterior pharyngeal wall. The superior aspect is at the soft palate. The inferior aspect is of the vallecula. And then the tonsil forms the lateral pharyngeal wall. So when we start looking at specifically tumors that are involved in the region of the oral pharynx, we'll first talk about the tongue base. Now, what is a tongue base? The tongue base is a part of the tongue, but it's delineated by this area of papilla, which are chevron-shaped in the circumvallate papilla. And right at the apex here of the circumvallate papilla is the foramen cecum. So when we look at the tongue base, it's all of this region that's posteriorly. So this is an example of squamous cell carcinoma that's involving the tongue base, and this is what we see on CT imaging. So how do we know that we're actually looking at the tongue base? When we look at CT scans, these muscles that go from anterior to the posterior are in actually a different area of the head and neck. And we'll talk about this later because this is in the oral cavity, and this is specifically in the floor of the mouth, and we'll come back to that later. But what I do want to highlight is notice how these vertical striations end here, and now we have these transverse striations, and are the intrinsic muscles of the tongue base. So this is the example of a classic tongue-based carcinoma. Now, when we look at imaging findings for a tongue-based carcinoma, they really are nonspecific. So these are examples of a tongue-based carcinoma on CT, and this is what it looks like on MR. In a couple of examples, we'll be showing other types of tumors, but unfortunately, we're not very good at distinguishing based on imaging alone. However, if we are looking at an adult that has a tongue-based carcinoma and we see a lymph node like this that sometimes you can refer to this as cystic or has low attenuation, we can suggest that this is an HPV positive tumor. Now, when we talk about oropharyngeal carcinomas, we know that the majority of oropharyngeal carcinomas are going to be HPV positive. And so back in the 2000s, I actually saw, if you will, this epidemic first be identified. So now we know that at least in the United States, about 80 to 90% of HPV positive, of oropharynx cancers are going to be HPV positive. And these are predominantly involved in the tongue base and the base of the tongue. We know it has a better prognosis. But on the other hand, when we talk about oral cavity cancers, these tend to be HPV negative tumors. And again, when we step through the subsites of the oral cavity, we'll highlight this as well. Now, one of the interesting things that we get into when we actually talk about oropharyngeal carcinomas is that we know that HPV positive carcinomas have a better overall outcome. And so when we go to our multidisciplinary tumor boards, and I completely agree with Dr. Shah, is that cancer is not treated by a single person, it's actually treated by a team. So when we get together in our multidisciplinary tumor boards and we see someone that comes in with a tongue-based carcinoma, or as we'll see lately with in a couple of slides about a tonsillar carcinoma, we know that oftentimes these can either be treated surgically or non-surgically. So where radiology has really made a difference is that I don't necessarily believe in standardized reporting, but I do try to include these things that I refer to key elements in my report. So if I just say that there's a cancer involving the tongue base or the tonsil, well, I haven't really told the surgeons very much. Rather, when we get into a tumor board situation, what we want to do on imaging is identify specific imaging findings that's going to directly affect how these patients are treated. So when we talk about oropharyngeal carcinomas, the things that I try to include in my report is, first of all, is there any evidence of deep extension? So notice how there's deep invasion here. does the tumor cross the midline? Because if it crosses the midline, the surgeons in general need to take a 5 millimeter to 1 centimeter oncologic margin. And if it crosses midline, then in this case, they may have to perform a total glossectomy or near total glossectomy. Is there evidence of peripharyngeal invasion? If there is an unresectable lymph node, oftentimes at our institution, the surgeons may elect to treat this with non-surgical organ preservation therapy. Is there any evidence of bone invasion? Or is there any evidence of retropharyngeal metastases? Are the carotids in the retropharyngeal space? If these carotids extend medially into the retropharyngeal space, oftentimes our surgeons will not operate in these patients because it's in close proximity to the tumor. And is there any evidence of prevertebral fascia invasion? So these are the things that I try to include in my report when I'm trying to identify those patients with HPV positive oropharyngeal carcinomas to help our multidisciplinary team make the right decisions. So we know that the most common tumor to involve the oral pharynx is going to be squamous cell carcinoma, but we also know that there's small little rests of minor salivary gland tissues. So other tumors that can involve the tongue base include lymphoma, which is the second most likely tumor, but these are also examples of minor salivary gland tumors that can involve the tongue base. And again, as I mentioned before, unfortunately, we really can't tell the difference. This is adenoid cystic, and this is a polymorphous adenocarcinoma. So in situations like these, we sort of leave it up to the pathologist. The one thing that I have noticed from my experience, if you will, is that if I see a large mass and there's no mucosal lesion, then I start being a little bit more leaning towards a minor salivary gland tumor if all of the tumor is submucosal. But again, that is doesn't always work. The next area that we'll talk about in the oral pharynx is the tonsil. So when we talk about the tonsil actually has three components to it. The main part of the tonsil is the palatine or the fascial tonsil. Then we have this area of the tonsil here, which is the anterior tonsillar pillar, and then we have this area here, which is the posterior tonsillar pillar. So from this lecture, I actually have another 50-minute talk purely on the oral pharynx and tonsillar carcinomas. So in this talk, we'll just primarily identify just on the tumors that involve the palatine tonsils. So when the patients present clinically, you can actually see the tumor involved in the left tonsil. So one thing that I do in my clinic is I actually go to clinic and I see patients Wednesday afternoon. So I know when patients come in, I can oftentimes see the exophytic mass and the surgeons can palpate a very hard mass. But what they can't do is identify this deep extension. They don't know whether it's extending deeply to involve the masticator space and the peripharyngeal space, or it's creeping posteriorly to involve the carotid space. And again, this makes a big difference as to determine whether you want to treat this with chemotherapy and radiation therapy, or do you want to treat it with surgery. So both of these patients are different patients. This is an example of an exophytic tonsillar carcinoma. Notice how it's all exophytic. There's no deep extension. So this can easily be treated with a tonsillectomy through a transoral robotic surgery. But in this case, here's a tumor on the left side. And if I draw a line down the middle and compare the right side to the left side, notice how on the right side we can see the peripharyngeal space, we can see the medial pterygoid muscle. But on the left side, notice how this tumor is extending deeply. It's involving the peripharyngeal space. It's abutting the medial portion of the medial pterygoid muscle, and it's also extending anteriorly and abuts the posterior margin of this muscle, which is the mylohyoid muscle. So from my standpoint, anytime that I see this, and I also say this tumor is in close proximity to the carotid artery, I'm not necessarily telling how to treat these patients, but this type of information needs to be integrated through this thought process. And from a surgical and a radiation oncologist standpoint, they can take these key elements and then determine how to treat these patients. The next area that we'll talk about is the soft palate. So when we talk about the soft palate, we know that this is an area of soft tissue that extends posteriorly to the hard palate. So the hard palate, as we'll see later, is in the oral cavity, but the soft palate is located in the oral pharynx. So when we look at the soft palate, this is that area of the soft palate. This is that tip of the uvula. And when I think of the palate, I tend to think of the Roman arch. So when we look at the soft palate, we talk about the palatal arch. So these are the muscles that comprise the soft palate, and then we have these two muscles that extend from the palatal arch to the skull base. So I sort of think of this as a Roman arch. So these are my tonsillar pillars on each side. This area right here, this arch right here represents the palatal arch. And in order to have the palatal arch be firm, it is connected right here to the skull base. And these two muscles that connect the palatal arch to the skull base are two muscles we learned about in medical school, and those are the tensor and the levator veli palatini muscles. So these two muscles tether the palatal arch all the way to the skull base. So one of the things that I've noticed about when we're evaluating patients with squamous cell carcinomas of the soft palate is because the soft palate traverses the midline, sometimes it can be hard to see these tumors on axial images because they do traverse the midline. So this is an example of a soft palate carcinoma, and quite frankly, at times it's hard to see. We can see maybe there's a little bit of airway narrowing here. Notice how the carotid artery is extending into the retropharyngeal space. So this is information that I include in my report. But on the sagittal images, we can see there's no ambiguity regarding this soft palate carcinoma. So this right here is pretty easy to see. Now, I would say the majority of soft palate carcinomas are relatively easy to see on clinical examination. But what they cannot see, especially in the clinic, is whether or not these tumors extend superiorly. So this is an example of a left-sided soft palate carcinoma. And if I draw a line down the middle, compare the right side to the left side, what I want to do is point out the normal surface anatomy and that anatomic area just superior to the soft palate, and that's the nasopharynx. So this is the torus tubarius, this is the opening of the eustachian tube, and this is our famous fossa rosebular. So anytime I see a soft palate, especially when it's ipsilateral, I always want to look at the torus tubarius. So notice how this torus tubarius is thickened. And then when we do an MR scan, what we see here is diffuse enhancement of this torus tubarius. And this is all tumor that's growing up along a superficial muscle that surrounds the torus tubarius, and that's a salpingopharyngeus muscle. So if our surgeons are trying to decide whether or not to resect the soft palate carcinoma, what they cannot see, oftentimes, especially in the clinic, is this superior extension. And again, this is where imaging has made such a big difference in the spread patterns of these tumors. Now, there are other tumors that can involve the oropharynx. This is an example of Kaposi sarcoma. This is an example of rhabdomyosarcoma. And this is Burkitt's lymphoma. Now, in this is Kaposi sarcoma and Burkitt's lymphoma. It's pretty rare to see this in the United States. Notice how the imaging findings are nonspecific, but if you are in areas that are endemic to this type of tumors, you have to always include this in the differential diagnosis. So these were the Kaposis and Burkitt's were slides that were given to me by my friends in Tanzania. And if you look real closely right here, you can actually see a metastatic retropharyngeal lymph node. If I do see a large mass involving the oropharynx, we know the most common soft tissue malignancy in a child is rhabdomyosarcoma, so that goes to the top of my list. So the bottom line is that when I start seeing these tumors involving the oropharynx, the imaging findings are nonspecific, so I have to factor in the age of the patient. I also have to factor in where these patients are from, and therefore I can give a little bit more of a complete and thoughtful differential diagnosis. So the next area that we will talk about is going to be the oral cavity. So when we talk about the oral cavity, we're now going to move a little bit more anteriorly. Now, as I mentioned before, oropharyngeal carcinomas are HPV positive, whereas the majority of oral cavity cancers are going to be HPV negative. And I'm specifically speaking more towards the United States. You know, in my travels around the world, I noticed that there are different incidences of HPV positive tumors in oropharynx cancers. But in general, in Europe and the US, we know that HPV is more likely in oropharynx cancers, and these tumors involving the oral cavity are less likely to be HPV positive. So when we look at the different subsites of the oral cavity, there are 6 primary subsites. We have the buccal region, we have the floor of the mouth, We have the alveolar ridge in the mandible, which I'm not going to be talking about specifically in this talk, just purely because of time. We'll talk a little bit about hard palate cancers, oral tongue cancers, and also spend some time on the retromolar trigone. So the contents of the oral cavity are the lip, the buccal mucosa. So this is our lip right here. This is the buccal mucosa here. This is the gingiva, and this area right here is the gingiva buccal sulcus. We then have this area back here, which is going to be the floor of the mouth. This is the area of the mandible, and where the teeth insert right here, this is what we call the alveolar ridge. And as I mentioned before, then we have the oral tongue, and we'll say a little bit more about the retromolar trigone later. So the first cancer area that we'll talk about is the buccal region. So when we look at the buccal area, I have learned to call this the buccal region. The reason why I do this is that if I'm giving a talk on the spaces of the head and neck, so if I'm giving a talk on the spaces of the head and neck, then I'll refer to this as the buccal space. But on the other hand, when I go to clinic and I see patients and they have tumors in this area, this is oftentimes in the region of the gingiva buccal sulcus. So you can have tumors arising from this sulcus, and I'll go back just one slide. You could have tumors that are rising here along this gingiva, or you can have tumors, along the buccal area, or you can have tumors around in the gingiva, and then you can have these tumors that extend all the way deeply into the sulcus. Now, the most common tumor to arise in this sulcus is going to be squamous cell carcinoma. Now, in the United States, what predisposes us to squamous cell carcinomas in this specific region is that many times in the US, we have people that dip snuff. So you take a little bit of this snuff, you put it between your cheek and your gum, and the direct toxicity of the snuff can result in squamous cell carcinomas arising from this area. Now, I know that many of you on this call are from India, and in India, we have our own version of this, and this is the betel nut. So all of you that are using betel nut right here, if you do put the betel nut, you are exposing this to a higher likelihood of developing squamous cell carcinomas. And again, these tend to be HPV negative. And what's amazing to me is that when I see patients in clinic, I've seen patients with betel nut-induced squamous cell carcinomas and snuff squamous cell carcinomas. And if there's any doubt that I ever had about the direct toxicity, it was eliminated, because it's amazing when I see these early cancers from the betel nut, it is exactly where the patient tells me they put their betel nut and exactly where they tell me they put their snuff. So there's absolutely zero ambiguity that these types of betel nut or snuff results in squamous cell carcinoma. Now, as I mentioned before, on this right-hand side, this is an example of squamous cell carcinoma involving the gingiva buccal region or the gingiva buccal sulcus. Now, the challenge that we get into in radiology is sometimes we don't know whether it's arising from the buccal surface or whether it's involving the gingival sulcus. So what we can do, a little trick that we try to do, is that when we do have a patient that comes in with this type of tumor, we have them puff their cheeks. And what the puff cheeks techniques does, it separates the lip here from the overlying gingival mucosa. And as a result, we can now see that this tumor is involving the lip itself. And this is another example of a tumor that's involving the lip. So clinically, it doesn't make that much of a difference because you can see these tumors, but radiologically, when we are doing our report, this little puff technique I have found to be helpful over the years. Now, when we come into the key elements about what we want to report when we're talking about squamous cell carcinomas involving the oral cavity, remember these squamous cell carcinomas, the majority of them are going to be HPV negative. And as a result, I can only talk about in the US, the mid to early stage tumors are typically treated with surgery. So when the patients come in, as in this case, you do not need to perform a CT scan to identify this primary site because this tumor is just looking at you. You can see it's ulcero-infiltrative. But from a surgical standpoint, the surgeons need to know whether or not they can perform a local excision, a wide local excision, or whether they have to perform something more aggressive. And so the key element that we always have to look for, especially in lesions involving the gingiva buccal sulcus, is whether or not there's erosion here of the bone. If there's erosion here of the bone, then the surgeons are going to have to have some type of surgical procedure. And a lot of this depends on the extent of the erosion and also how much of the bone is involved. So it's not only the cortical erosion, but the anterior posterior extension. So in this case, if we do say that there's erosion of the body of the mandible, then the patients are going to have a segmental mandibulectomy, and then they're going to have to be reconstructed. Now, there's a variety of reconstruction tools that can be used. This is the classical example of a fibula using an osteocutaneous flap. You can also perform some type of not a radial forearm flap, but a piece of radius has been now used too. So there are various types of permutations. But from our standpoint, anytime that patients have this type of erosion right here, this bone erosion, then this usually necessitates some type of free tissue transfer and some type of free flap. And it was mentioned earlier, these are much more extensive procedures that require substantial surgical planning. But on the other hand, this is where we've really made a difference in head and neck imaging, because we are the ones based on our imaging that determine whether or not these tumors can be treated with wide local excision or they have to undergo some type of composite resection. So the next area that we'll talk about for the oral cavity is going to be the oral tongue. Now, when we talk about the oral tongue, there's actually two names to the oral tongue. So let's go back and review the anatomy. So we all know this is quote unquote the tongue. Then we have the chevron-shaped papilla that we talked about earlier. This is the circumvallate papilla. The foramen cecum is posteriorly, and posterior to this is the tongue base. So this was the part of the oropharynx, and this is the area where we have HPV positive tumors involving the tongue base. Now, everything anterior to the circumvallate papilla is referred to as the oral tongue or the mobile tongue. And this has a different embryologic origin from the tongue base. So when we do talk about lymph node spread for the tongue base, this typically tends to drain to level 2 ipsilaterally and contralaterally. But when we talk about the oral tongue, because of the embryology, the primary echelon drainage of these types of tumors tend to be level 1 and level 2. Also, the tongue base has cross lymphatics, so essentially for larger tumors, both sides are at risk. But if you have an early stage oral tongue cancers, in general, this places the ipsilateral side at risk. Now, if it's more advanced, the contralateral side is as risk too, but just realize the lymphatic supply is different, and a majority of that is based on the embryology. So many of you may know I've been the radiologist on the AJCC staging system since the 5th edition. So I've been doing it from the 5th to the 8th edition. And so I did want to highlight the changes in the 8th edition of the AJCC compared to prior editions. So number one, oral cavity cancers we know majority are going to be HPV negative. Now, when we look at the prior editions, size is an important value when I'm trying to identify the staging. So if you have a T1 lesion that's less than 2, it's going to be T1. T2 to T4 is a determinant of a T2, and then anything greater than 4 centimeters is going to be T3. But what we did add into the new staging system is the presence of depth of invasion. Now, I want to emphasize that depth of invasion is a histologic diagnosis. It is not a radiological diagnosis based on the staging criteria. And so when we talk about depth of invasion, if it's less than 5 millimeters, it's a T1. So how do we make this measurement? Well, what the pathologist does is they take a piece of specimen and they try to identify the basement membrane. Then they approximate the basement membrane. Now, I don't remember much from histology. The only thing I remember is blue is bad. So blue is bad. So what happens is that when you approximate the basement membrane, you then draw a plumb line and you measure the depth of invasion from the basement membrane. So it's basically a 90-degree plane. So anytime that you see blue right here, see all this blue right here, this tells us where the tumor is. And then the pathologists go ahead and measure this depth of invasion. So this depth of invasion is now integrated into the staging system. So if you do have a tumor that has greater than 10 millimeters of depth of invasion, and it has a size from 2 to 4, again, that indicates a T3 lesion. So oftentimes what I see is that radiologists will do a cross-sectional imaging and they'll measure from here to here and they'll say that's depth of invasion. That is not truly depth of invasion. That's tumor thickness. Now, I have seen recently, and I'm sure there'll be more research done, is that if you have a purely ulcero-infiltrative lesion that's involved in the mucosa of the tongue that purely extends inferiorly without bulk, then that could be a good surrogate to measure depth of invasion. But I do want to emphasize, based on the 8th edition alone, right now, this orthogonal measurement right here is not depth of invasion. That is actually tumor thickness. So number one is that when we do our imaging study, we can measure the size of the tumor, and I always measure the size of the tumor. But the next thing that was mentioned is we have to figure out the type of treatment these patients can undergo. And again, this is so much dependent on imaging. So if you have a tumor such as this, which is located along the lateral margin of the oral tongue, and you can see that it has maybe 7 or 8 millimeters of thickness, it does not cross the midline, well, these can be treated with a nice wide local excision. So this is a very, very simple surgery that our surgeons can perform. But on the other hand, if we have a tumor such as this that's completely involving the tongue, so when we have a tumor like this, we're talking about this spread pattern that crosses midline, then you really have to have an interesting discussion, especially now in 2025. Because if this tumor crosses the tongue, then the surgeons always want to try to get a 5 to 10 millimeter oncologic margin. So for us as radiologists, it's really important to identify how far this tumor crosses over. Because if the tumor barely crosses over, well, maybe the surgeons may perform a partial glossectomy or subtotal glossectomy. But on the other hand, if the tumor completely crosses over, then the only type of surgery that can be performed would be a total glossectomy and a laryngectomy. Now, over time, we've seen that this surgery is less commonly performed. But on the other hand, what I have noticed is that the decision to perform this type of surgery for a tumor that completely involves a tongue really varies. I know at many institutions right now, these are all treated with chemotherapy and radiation therapy. In my personal opinion, is that I think in all tumors that involve the oral pharynx or the oral cavity, I think they should all be tested for HPV. Because I think I can make the argument that if I have a tumor that's completely replacing the tongue and it turns out to be HPV positive, well, these tumors may be more amenable to combined chemotherapy and radiation therapy as opposed to just doing a total glossectomy. So these are all things that we're all trying to vet out right now because the information continues to change. The next area of the oral cavity that we'll talk about is the floor of the mouth. So when we look at the floor of the mouth is also called the sublingual space. Now, again, I have seen some people call the floor of the mouth purely this individual muscle, and this muscle that goes from the myeloid line to the hyoid bone is called the mylohyoid muscle. In general, for me, I tend to use the term floor mouth and sublingual space interchangeably. So the sublingual space is that space that's located below the tongue. So when I look at the anatomy of the sublingual space, I look at the mandible right here. So this medial margin of the mandible, and specifically this line right here, which is called the myeloid line, this attachment of the mylohyoid muscle to the myeloid line down to the hyoid bone forms the lateral margin of the floor of the mouth. Then we have this gland right here. This is the sublingual gland. We have a duct right here, as we can see on the sagittal images. This is Wharton's duct. We then have a nerve right here. This is the lingual nerve, a vein, and then the hypoglossal. Then we have another muscle right here that goes from the hyoid bone to the tongue. Instead of saying lingua, which is Latin for tongue, we now flip the roots, and glossus is Greek for tongue. So we call this the hyoglossus muscle. Just medial to the hyoglossus muscle is an artery, and that's the lingual artery. So when we look at the floor of the sublingual space or the floor of the mouth, to me, when I look at both sides, it almost looks like a teacup. So the rim of the floor of the mouth, or the rim of the teacup, is the mandible. This area right here, the wall of the teacup, is going to be the mylohyoid muscle. The base of the teacup is going to be the hyoid bone. And all of these contents that we discussed are going to be located in the lumen, if you will, of the teacup. So when we look at tumors involving the floor of the mouth, again, we have made such a big difference in how these patients are treated. So here's a schematic illustration of a tumor involving the floor of the mouth. So the most common tumor, again, is going to be squamous cell carcinoma. And this is an example of an ulcero-infiltrative lesion involving the floor of the mouth. So this is what the surgeons see. So when I go into clinic on Wednesday afternoons, this is what I see. So the surgeons can measure the tumor, but from their standpoint, they want to know the type of surgery options they can present to the patients. So is this a tumor that they can perform a wide local excision on? Is it a tumor where they can just take a little bit of cortex, or is this a patient where they have to take the whole mandible out? So this is an example of a tumor that's involving the floor of the mouth. Now, what I want to do is give you just a way that I look at this. So this is a patient that has a left-sided floor mouth carcinoma. But the way that I look at this and I define my spread patterns is I draw a line down the middle and then I compare the right side to the left side. So for me, I like to look at my tiger stripes. So I can see the mylohyoid muscle here, I can see fat, and I can see these little bright dots right here, which are branches of the lingual artery. So this is my normal on the right side. Now, when I look at the left side, notice all my tiger stripes are gone. So if I was to evaluate this, I would say there's a left-sided soft tissue mass involved in the floor of the mouth. The lesion extends medially, it surrounds the lingual artery, and abuts the lateral margin of the genioglossus geniohyoid complex. So in something like this, then I can tell the surgeons and they can take that information. But the next thing that we always have to do is determine whether there's bone erosion. So again, this arrow points at a tumor. And again, I want you to look at my tiger stripes. Notice some nice stripes here on the right side, but on the left side, my tiger stripes are obliterated, and we can see the tumors directly abutting the lingual cortex of the mandible. Now, from a surgical standpoint, when we go in and we examine patients on Wednesday, sometimes the surgeons will say, well, I see the tumor, but I just don't know whether it's involving the mandible. Sometimes they can get their full finger around it. Sometimes it can be mobile, but sometimes it's just hard to assess that deep extension. So what we have to do is always reconstruct in bone algorithms, not bone windows, but bone algorithms. And in this case, we can see that cortex is completely intact. So in this particular situation, what I will tell the surgeons is I'll give them the size of the lesion. I'll tell them where it's located. I will say it's extending anteriorly because this is where the submandibular duct exits. So this is all information they can use. But on the other hand, this is another example of a patient that has a squamous cell carcinoma involving the floor of the mouth. So again, look at my tiger stripes. We see a nice clean lingual septum. Here's the mylohyoid muscle. This is going to be the hyoglossus muscle. Very, very nice gray, black, very nice tiger stripes. Here we can see that tumor is completely involving the left floor of the mouth. But again, reconstructing bone algorithms, and unfortunately, this was a study that was initially sent in from the outside, and the bone erosion was missed. So when we do see this bone erosion, I have to tell the surgeons that this cortex right here is eroded. And if you look real closely, we can also see some increased attenuation. Now, whether or not this is due to tumor involvement or due to osteitis from really bad odontogenic disease, I think it's really, really hard to say. But at the very least, we have to mention this bone erosion. And then it's really up to the surgeons and the whole team to determine the type of mandibulectomy that needs to be performed. Now, there are other tumors that can involve the floor of the mouth. In this case, this was a minor salivary gland tumor, this was a neurogenic tumor, and this was a mesenchymal tumor. Again, we're not very good at identifying the specific histology. In this particular case, we can suggest it because it's located in the area of the lingual nerve. In this case, we have a lot of fatty tumor, and this turned out to be a liposarcoma. But in general, again, we're not the best at looking for these tumors. So the last two areas that we're going to talk about are the retromolar trigone and the hard palate. So the retromolar trigone, the way we identify this is the central incisor, lateral incisor, canine, first premolar, second premolar, first molar, second molar, third molar. And that area behind the third molar is the retromolar trigone. So if you've ever had your wisdom teeth removed, congratulations, you have the largest retromolar trigones on this seminar. So here's an example of a squamous cell carcinoma involving the retromolar trigone. Now, in my experience, and I can say this because I'm old, most understage tumor involved in the oral cavity that I've seen are retromolar trigone carcinomas. And that is because they're tucked away behind the molar. So when you look in someone's mouth, the surgeons can see these the outside of the tumor, the medial portion, but they cannot identify this posterior or the lateral spread. So this is an example of a retromolar trigone carcinoma. And what these things tend to do is that they have early bone invasion. And the reason, at least in my opinion, why the bone's invaded is that if I take a 3-centimeter tumor and I plop it in the oral tongue, well, it's just going to grow from one side to the other. But if I take that 3-centimeter tumor and then I place it right here into the retromolar trigone, well, as it moves posteriorly, it's going to have a higher incidence of eroding the bone. So I can't tell you how many times I've seen tumors that are felt to involve the posterior mandible, but when we look at the imaging study, they've crept all the way back in the retromolar trigone, and in this particular case, it's eroded the anterior portion of the mandible. Now, I mentioned earlier my tiger stripes, and for me, I think all patients with retromolar trigone should get CTs and MRs. And the reason is, and you'll see in the next slide, is that early likelihood of invasion of the bone. So the normal anatomy right here is that you have the superior constrictor muscle, the buccinator muscle, and where it interdigitates here is called the pterygomandibular raphe. These tumors in the retromolar trigone can jump on this pterygomandibular raphe and grow all the way up to the hook of the hamulus. So when the surgeons are contemplating what type of resection to perform, we as radiologists always need to look very, very closely. And notice in this case, see the fuzziness right here of the fat anterior to the body of the mandible? Notice the fat is clean on the left-hand side. And look, see this thickening right here? And look what's right here. This is the hook of the hamulus. So this tumor has grown all the way up to the inferior portion of the skull base. That's something that we really cannot see clinically. And the other thing we always have to look for is whether or not that bone is actually eroded. Finally, after years of working with my surgeons, now on retromolar trigones, all of our patients tend to get MRs as well. And specifically, what we look for is replacement of the fat in the body of the mandible. So here's a large retromolar trigone carcinoma, and here's an obvious case of involvement of the fat of the ramus of the mandible. And normally, it should be high T1 signal. Notice how it's been replaced. But on the other hand, this was a patient, I think I was out at that time. This patient had a retromolar trigone carcinoma. And on the contrast-enhanced T1 weighted images, notice how we have all of this enhancement involving the mandible. On the left-hand side, notice there's no enhancement. Well, unfortunately, the surgeons didn't necessarily appreciate this. They went in and they did a partial mandibulectomy. And unfortunately, when they came back, there was a positive margin. So after that, we finally convinced our surgeons to always get MRs when we're doing retromolar trigone and specifically look for this involvement of the mandible. And the last thing that we'll end up with is the hard palate. So when we look at the hard palate, these are relatively easy tumors to see on imaging, but the big challenge is whether or not that bone is involved in these other types of spread patterns. Because if we say that the tumor is just involved in the mucosa, then the surgeons can just do a wide local excision. But if we say there's involvement of the bone, then the surgeons have to do a maxillectomy. So there are various other types of tumors that can involve the hard palate. The most common is going to be squamous cell carcinoma, but because there is a high propensity of small little minor salivary gland rest, the second most common tumor to involve the hard palate are going to be minor salivary gland tumors. And these include things like benign lesions such as pleomorphic adenoma, but you can also have malignant minor salivary gland tumors such as mucoepidermoid carcinomas. Again, we're not the best at trying to distinguish these two. If I see something like this in the hard palate and it has high T2 signal, I can suggest pleomorphic. But on the other hand, we cannot be 100% sure. But what I want to leave you with is that when we are dealing with patients with hard palate carcinomas, if it's involving the mucosa, it's going to be a wide local excision. If it involves a hard palate, the bone, then they're going to have to do a maxillectomy. But I always want to remind you of the various nerves that involve the hard palate. And especially when you have tumors such as adenoid cystic carcinoma, these tumors can jump on the greater and the lesser palatine nerves and grow towards the central skull base. So this is the normal greater palatine foramen on the uninvolved side. This is a patient on the left-hand side, and we can see enlargement of the greater palatine foramen. And as a result, these tumors can grow up along the pterygopalatine fossa. It can involve the sphenopalatine ganglion. It can grow all the way up along V2. And once it jumps to these nerves, it can grow posteriorly into the central skull base. So this is an example of an adenoid cystic carcinoma involving the pterygopalatine fossa. If I draw a line down the middle, compare the right side to the left side, notice the evil gray right here. Notice the normal fat. This is telling us the tumor is back in the pterygopalatine fossa. And once it's back in the pterygopalatine fossa, as I mentioned before, it can have retrograde perineural spread. So if I draw a line down the middle, compare the right side to the left side, I think you can see this big enhancing tumor. This is retrograde perineural spread along V2. And if you look real closely, here's the normal appearance in the right side. The target sign here is V2 surrounding the vascular plexus. But if you really have a sharp eye and you remember the anatomy, I mentioned this earlier, this is the nerve of the Vidian canal. So here's a normal nerve of the Vidian canal on the right. And on the left-hand side, lo and behold, there's actually abnormal enhancement along in the nerve of the Vidian canal. And when we look back in the cavernous sinus, this tumor's grown all the way back in the cavernous sinus. And I know when we had that beautiful summary of the surgeon's perspective, he mentioned how things have really changed, how imaging has changed surgery. Now, I've been doing this for about 35 years right now, and I just want to completely confirm that. Back in the old days, when I first came to India in 1995, my father had just passed away, and I was taking his ashes to Haridwar. And I was also giving some talks when I was there. And I remember showing a case of perineural spread in 1995, and someone in the audience got up and said, "It's a miracle. We can actually see these nerves." And moving forward, even in the late 1990s, when we would start talking about perineural involvement in the central skull base, some surgeons at that time really didn't believe us. And so when you had these tumors that were involving the central skull base, many surgeons would still chase this back all the way into the central skull base because they didn't necessarily believe radiology. And as a result, these patients would have huge deficits. They would have deficits involving 3, 4, and 6. You would also have to resect the cavernous sinus and the carotid artery, incredibly morbid. But one of the big things that I've seen over the last 30 years is the partnership between our surgeons, our radiation oncologists, radiologists, nurses, all of our rehab people, because now when we look at this abnormal enhancement, many of these patients where we as the radiologists say the tumors are growing into the cavernous sinus are not being treated with surgery, but they're actually being treated with chemotherapy and radiation therapy. So in summary, what I've tried to do over the last 40 minutes is talk about the anatomy of the oral pharynx and the oral cavity. We predominantly talked about squamous cell carcinoma. We can talk about lymph nodes later on if that interests the group. And then I just would like to point out, we do have, if you want to follow me on YouTube, X, and LinkedIn, and this is a free YouTube channel. I have about 20 lectures on this channel. If anyone's interested, it's free of charge. It's just my small little contribution to education. And then in about 3 weeks or so, we are going to be starting our online head and neck remote fellowship through Modality. So thank you very much for the privilege of being here. And I'm happy to answer any questions you may have.
Thank you. Thank you, Dr. Mukherjee. That was a really enlightening talk. And it was a privilege to hear someone with so much experience and so much interest in both the anatomy and the radiology. And as you've been the part of various MDTs, you know how the decision making works. Thank you so much for this lecture. I hand it over to Dr. Sahu to take it further and thank Dr. Mukherji.
Thank you, Dr. Mukherji, for the wonderful talk. Now I invite you and Dr. Sharma to take over the Q&A session. Like if someone has any questions, like we can discuss on how the imaging and from the surgical point of view. So welcome, Dr. Sharma and Dr. Mukherji for this Q&A session.
Sure. So if there are any questions, I can see no questions in the chat, but if there are any questions, please feel free to ask. Otherwise, I have one or two things that I want to clarify.
Yeah, I think you can go ahead with your questions
So,
till others are.
Dr. Mukherji, you talked about bone window versus bone algorithm. Can you clarify for us how they are different?
Yeah, so there is a difference, and our radiology colleagues know this. What happens is that when you acquire the images, oftentimes what happens is that you have the ability to take the data and create it such that it optimizes our ability to see the tiger stripes that I was talking about. So when we talk about spread patterns, you can take that data and then manipulate it, and it gives you a very good images to look at the soft tissues. Now, you have the capability, once you have that type of reconstruction, to basically, it's like turning on your TV and turning the dials, and you can kind of go away from the soft tissues and you can see the bone. But on the other hand, when you are looking, especially with you as an accomplished head and neck surgeon, what you want to know is the degree of cortical erosion. And the early forms of cortical erosion are not going to be reliably seen if you're just looking at bone windows. So when that data is then generated by the CT scan, while it's still in the scanner, the technologists also have the ability to reconstruct these data into high resolution bone algorithms. So instead of optimizing for the soft tissue, they can optimize for the bone. And they have various pathways, various even degrees of detail. And part of that is to work with radiologists to figure out what detail that you want to use. So it's just that as the data comes out, it's sort of redirected. And you can do both. In the old days, it would take an hour to do each reconstruction. I trained in the last century. I was born in the last century. I still remember CT before multi-detector CT. And on those days, it would take about 30 seconds to a minute to do a single rotation. And the reconstructions would take anywhere from 30 minutes to an hour to do. But now it's much easier. So that's why I think bone algorithms should be done, especially if you're at a cancer center.
I think you are on mute.
One thing that we actually look at when deciding the extent of mandible resection nowadays is whether we can get away with a marginal mandibulectomy without removing the entire segment of the mandible. Earlier, what we used to practice was that if there's any cortical erosion or any, this I'm mainly talking about buccal mucosa or the sulcus tumor. So if there's any cortical erosion, we go for a segmental mandibulectomy. Nowadays, if we can get a 1 centimeter remnant of the mandible at the at the inferior margins, we do tend to resect the bone even if the cortical margins are involved and the alveolar canal is free. So have you seen that in practice, and do surgeons ask for that in your practice?
Yeah, that to me is the hardest decision to make. What you identified, there are so many facets of it, and I've lost sleep numerous times because I don't want to. I've been doing this for a while. I have a little bit of expertise, but sometimes what happens at our tumor clinic is they'll come to me and they'll say, "Well, how much of the mandible do I need to take out?" And so sometimes I lose sleep as a radiologist because all of a sudden I'm realized that I'm the one that's going to be determined. We'll actually say, well, you take your cut here and you take your cut here, which I appreciate, but it scares me. But, as a result, I think about exactly what you're saying. So these are my thoughts on this, and I'll try to be concise. In general, if the tumor is fixed to the mandible, but there's no cortical erosion, then oftentimes our surgeon will take a little sliver or a little cut. And what they'll do is they'll go ahead and take a little sliver, then they'll send it for a frozen. So they'll send it for a frozen. If it's done, then they're all done. The biggest challenge that I run into is that if I see a little bit of erosion along the lingual cortex of the mandible, the next thing that I look at is what does the underlying bone look like? Because at least in our patient population, the majority of patients that have squamous cell carcinomas tend to be men, and they oftentimes don't take care of their teeth. So the challenge that runs in is that if you have a young patient like Vinita and Asutosh who take good care of their teeth and don't smoke or drink, and unfortunately may have something like that, well, then we can be really reliable to say, where is this cortical erosion? Your bones are going to be good. And then you can do very nicely to take out the bone. What happens is that in these older patients, they have all of this dental disease, all of this osteitis. And then we're sort of faced with this daunting task to figure out exactly where to make the cut. So from my standpoint, what I try to do is I look for the most anterior aspect of the erosion, the most posterior aspect of the erosion, and then I look at the coronal images to see whether or not I think the tumor is growing up along the alveolar ridge. Even if I do an MR, and we do a lot of MRs for oral cavity lesions, if you do have a lot of osteitis, that is going to result in replacement of the fat in the mandible itself. So in general, that's going to overestimate the amount of mandibular erosion. So from my standpoint, if it's early erosion and I do an MR in someone with bad teeth, I run the risk of having the surgeons take out too much mandible. But on the other hand, if they are going to do a mandibulectomy and it's going to be segmental, then we'll go ahead and do an MR, because then I can say where I see normal fat, that should be the posterior margin and this should be your anterior margin. So it's a long answer, but your question, as you know, is probably one of the biggest challenges that we faced when we're trying to figure out the type of mandibulectomy to perform.
Correct. So any other questions, clarifications anyone needs to ask, please feel free. Otherwise, this was such a comprehensive lecture that I don't think there's a lot of questions that will be there. You have covered almost everything, including the need for doing both CT and MR. And you are absolutely right. Marrow invasion is completely missed on CT scans. And we have landed up in a situation where the resection needed to be much bigger because the marrow was involved.
The only comment I will make real briefly is that in the US, we tend to be a little bit more CT centric. And the reason we do, and part of that is, there are various factors to it. I think part of it is, at least in the US, the majority of institutions are going to get PET CTs anyway. And in the US, based on our payment system, our patients are going to have to oftentimes pay out of pocket. And in general, we as physicians, and especially radiologists, keep this at arm's length. We just recommend, we don't worry about how things are paid for, but the effects that they have on patients. But from my standpoint, I feel that should somehow play a role. So in the US, overall, we tend to do more CTs and PET CTs because if the patients are going to get PET CT anyway, well, in general, that's going to solve things. On the other hand, when I am in Europe, in other parts of the world, I do think that you can see better tumor spread in the oral cavity, especially in the oral tongue and the tonsil and the nasal, certainly in the nasopharynx and also the soft palate with MR. So I don't want to downplay MR. I use MR more as a problem-solving tool. So if there are specific things on a CT or PET CT we don't know and it's going to affect the resection of these tumors, then we will absolutely 100% get MR. But in general, we don't end up getting a CT, a PET CT, and an MR because we do have to look at the specific externalities regarding the finances of the patient. Because what we don't want to do is have a patient, they undergo all this stuff. Unfortunately, the treatment doesn't work. They end up passing away, and then someone's left with not only the loss of a family member, but medical bills as well, too. So I think moving forward, I think we as physicians not only have to take responsibility for the images and the treatments, but also the eventual effects on the patient and the family members.
I think we have already crossed 7 p.m. So maybe we can, if there are not many questions are there. I don't see any questions. I think people have been thanking Dr. Suresh for his excellent talk. So I think I will now summarize and say thanks to all of you. So Dr. Suresh, it was really a very enlightening and very interesting lecture that you had, and you covered in so much of detail and so much of precision. This was very informative for all our participants. I thank Dr. Jayesh Sharma for your surgical, perspective on oral and tongue cancer. So thank you so much for giving us the details on it. I also thank Dr. Asutosh Sahu for being the moderator for the evening, and Mr. Jitendra Malik and the IT team of GAPIO for helping us organize this. I'm again sorry that Dr. Sonal Mahalwar, she couldn't join us because of her injury, and thanks to Dr. Mukherji for taking up the topic and giving us a full information on that. And last but not the least, I would like to thank all the audience who have joined us today and been with us in this talk. And I look forward to seeing you all again in the next webinar that we will be having in July 12th. So we keep having the webinars every other month in radiology. And probably I will again request for Dr. Suresh and Dr. Sharma to join us to give more information on radiology as well as surgery. So thank you so much, everyone, and good night. Good day to you all who are in the US and Canada. Thank you.
Thank you very much.
Good day.
Thank you.